Good morning, everybody, and welcome to today's Ask the Expert session on menopause. My name is Pete Wallroth. I'm the CEO and founder of Star, and I'm delighted this morning that we've got Alison MacBeth here to do this session for us. We're into our fourth year actually doing these Ask the Expert sessions, and the first one that we did back in 2021 was on the menopause. It was a brilliant session that we did back then, given the conversation, the way this subject has evolved. It's brilliant to be able to do another session on this subject and be able to pick through a number of different topics, as well as in some of our families that may join us as well. Before we actually get started into the session, just want to introduce Alison, and if you wouldn't mind just sharing a little bit about yourself and your background and your day-to-day role.
Hi, thanks so much for inviting me on. So I am Alison. I am a breast surgical specialty doctor for NHS Scotland. I spend most of my time working in breast cancer clinic in Glasgow. And my speciality is menopause after cancer, especially menopause after breast cancer. I'm a British Menopause Society accredited menopause specialist, and I'm a women's health GP. And I actually started life as a women's health GP, and I still do that. Work up for NHS Highlands doing women's health sessions. My life is mainly breast cancer and menopause. I run a secondary care menopause clinic for breast cancer patients in Scotland, and I work with Maggie's and breast cancer now, and I'm the medical advisor for Menopause and Cancer charity run by Danny Bennington.
Fabulous, thank you. I'm not quite sure how we're going to manage to wrap all that into an hour, but we will take advantage of as much of your expertise as we can. Right, well, without further ado, I'm going to put the first question to that we've got, which is around physical symptoms of menopause. And it's all in the context of obviously our families being diagnosed in or around pregnancy or postnatally as well. Many of our mums will end up with an experience of medical menopause as a result of their cancer treatment. For many, just as they see like their life is getting back on track and they're returning to some kind of normal, they start to experience menopausal symptoms, which can be really unpredictable, quite debilitating for somebody who's not expecting that to come into their life as a result of their cancer care. Bearing in mind, every individual person that we support is an individual, and how they experience those symptoms is going to differ from person to person. Can we talk a little bit about some of the physical symptoms that somebody could potentially expect to experience as a result of menopause, and what treatments could be potentially available for somebody in that situation?
Often it depends why the person is menopausal in the first place. Was it because of their chemotherapy? Was it because of radiotherapy? Was it because they've had surgery to take their kind of tubes and the ovaries out? It's what we call a surgical menopause, or what we call Zoladex, or kind of ovarian function suppression to turn the ovaries off. But in general, if a woman hasn't had cancer and goes through menopause naturally, what usually happens is your hormones slowly taper off. Whereas when you have menopause after cancer, it literally is like plummeting off a cliff. Overnight, your ovaries are pretty much turned off. The symptoms of menopause can often be about 10 times worse than a woman going through natural menopause. And your body's covered in estrogen receptors. So we've got them in our skin, our hair, our nails, our brain, eyes, mouth, bones, joints, ligaments, bladder, pelvis, heart, gullet. So menopause symptoms can literally affect any part of us. Normal menopause symptoms can be dry, thinning hair, dry, itchy skin, dry, itchy boobs or nipples is actually a really common one, breast pain. You can get the brain fog, the mood swings, the anxiety, poor concentration, poor memory, brain fog. So women think they're becoming demented, headaches, and the brain is really sensitive to fluctuating and plummeting estrogen level. The women will often get severe headaches or severe migraines, and then that leads to anxiety of, oh my goodness, do I have spread of cancer to my brain? And it's just those fluctuating levels. So the poor concentration, poor memory, joint pains, joint stiffness. You feel like a 100-year-old lady, especially with some of our cancer treatments. Acid reflux, bowel symptoms, and then what we call the genital urinary syndrome of menopause. And I have my four-shade vulva. Can everyone see this? This is what I bring to my Maggie's workshops. And I think it's so much nicer than these kind of like plastic models. Because when we talk about genital urinary syndrome of menopause. This is a very common symptom of menopause that can be really distressing. And in the old days, we used to call it atrophic vaginitis, which essentially just means dried out old lady vagina. And we don't call it like that anymore because it's so much more than the vagina. But you do get drying and thinning of all the vaginal tissues that can lead to a lot of discomfort, inability to sit, inability to have sex with your partner, inability to exercise. And that leads to kind of weight gain and low mood and depression. You get loss of the fatty tissue of the labia here. And it's essentially Mother Nature's biggest kick in the teeth. And you gain it everywhere else, especially in the tummy, but you lose fat in the labia. And again, it makes it really uncomfortable to sit or exercise. But you get lack of estrogen in the urethra here. So that leads to needing to wee all the time, or what we call the key in the door moment, where you get to your front door and you think, oh my God, I need to get to the loo, can't get there in time, or up all night weeing, which then disturbs your sleep. And then lack of estrogen to your clitoris here, which again leads to reduced sensitivity and reduced pleasure when you're trying to be intimate with your partner. And then there's all sorts of things like flushes. Everyone thinks of menopause as you feel a bit flushy, a wee bit grumpy, but it's, as I've said, it's just so much more than that. But the flushes and the sweats can lead to poor sleep. And then that spirals out of control because if you're waking up all night, you can't get back to sleep, and then you're often disturbing your partner, or you might be disturbing your kid. Your disturbed sleep leads to raised cortisol levels, which makes you put weight on and leads to brain fog the next day. And then that leads to inability to or reduced ability to function. So everything kind of spirals out of control. So there's a whole raft of symptoms there.
There are just pick up on something. It's this notion of disturbing somebody else by virtue of something that you can control. I think some of us are more aware than others are, but I think there's still a huge bit of education there that needs to be. This conversation needs to widen beyond women, and it needs to be, that awareness of the lack of control, the physical influence that this has, the mental influence this has on somebody, and it's still something I come across from time to time. Is this the flippancy that accompanies some of the discussion in the wider sense that it needs to be more about this as a collective impact on a person and partner, rather than be seen in isolation as it's just that woman who's experiencing this, because the influence and understanding will be so much better supported if the understanding was from partner's perspective as well. And I think we all have a job to do in that, in terms of spiking interest in making sure that we are show that understanding and empathy, even if we can't physically understand it.
You're completely right. It's just a significant impact on the partner, on the family, on work, on your colleagues, on your friends. So it isn't just the women. And then obviously if the woman's feeling exhausted, and that impacts on libido, which then also impacts on your relationship, as well as inability to be intimate because of all the vaginal issues. And then you're just exhausted. So it's the last thing you want. And again, everything just spirals. So yes, it's not just the women that's affected, and it's just so important to teach partners and colleagues and friends that these are significant long-term symptoms. And I think one of the problems is that people think, okay, they've had their surgery, they've had their chemotherapy, that's all out the way. My cancer treatment is finished, but you're continuing with, or some women might continue with endocrine treatment, but they often feel, okay, my acute treatment's finished and I just need to get on with things. But actually often it's the endocrine treatments that we use for many cancers often have worse symptoms or worse side effects than the chemo and the radiotherapy. And again, partners and colleagues and friends often don't understand this. So the woman's just left thinking, okay, I need to be back to normal, back to functioning. And yet I just feel so awful with the medications that you. So I know that you wanted me to talk about what treatments there are available for this. For menopause in general, your first line treatment is actually healthy diet and lifestyle. And you don't need to be doing any fancy fasting diets or anything like that. The Mediterranean diet is the one with the best evidence for menopause symptoms. And it also is the one with the best evidence to reduce risks of heart disease and osteoporosis. So we always recommend that one. And then exercise. And exercise is often the last thing that anyone wants to be doing. They're just feeling so exhausted, lack of sleep, joint pain. But if I can really encourage women to try and just get out even every day for a short walk, that's going to protect your bones, protect your heart, and boost your mood. Exercise can reduce the risk of cancer recurrence by up to 30%. We've got so much evidence about how important exercise is. We need to protect your bones. So again, you're walking, but also we know women gain a lot of weight in menopause. So the importance of a weights program, and you don't need to be doing big heavy weights or kettlebells. Just get some light hand weights or even resistance bands and do those exercises a couple of times a week as well. And that's going to help counteract that menopausal weight gain that so many women get and also protect your bones. And then your pelvic floor exercises are really important because as any women will tell you, it's the kind of the bladder leakage or the kind of the urinary urgency or needing to wee all the time or up all night weeing, and pelvic floor exercises are really important. If you don't know how to do pelvic floor exercises properly, go on the Squeezy app, go on Tena website. They've got lots of videos. You can get a referral from your GP to a women's pelvic health physio, and they are worth their weight in gold. We recommend vitamin D to every postmenopausal woman. If you just go to any pharmacy boots, grab the vitamin D off the shelf or vitamin D3, that's the one with the right strength. And then what we're going to do is talk about specific medications that we can use, non-hormonal medications that women can use for menopause symptoms. And one of the first line non-hormonal ones is oxybutynin, which is an old-fashioned bladder medication, but it's first line use for menopausal flushes and sweat and bladder symptoms. So it does a 2-for-1. And again, it's not just about a few flushes and feeling grumpy. It's really important to get these flushes and sweats that over 80% of menopausal women will have after cancer treatment. This can be an independent risk factor for heart disease. So really important that women just don't put up with it. And I see women every single day saying, okay, I can tolerate the flushes. It's the least of my worries. I'll just put up with it. But we say don't put up with it because it leads to poor sleep, which leads to then increased cortisol levels, puts your blood pressure up, puts your weight up, gives you brain fog, disturbs your family and your partner, and puts you at risk of heart disease. So oxybutynin is your first line medication to help with those flushes, and it also will help with bladder symptoms. In the old days, and probably lots of your ladies will have heard about clonidine, and GPs put women on clonidine. We don't use it anymore. It doesn't work. Another first line treatment is ultra low dose antidepressants now. And that's always a hard sell because when you mention antidepressants to women, they always think, oh, I'm being fobbed up. I'm being told I'm depressed. And that's not what we're doing. So with these medications in normal doses, they are anti-anxiety, antidepressant medications, but in ultra low dose, one of them's licensed for menopause symptoms, and we use them all the time for menopause symptoms. So not at antidepressant doses, but at menopause doses. And they work really well for flushes, sweats, a wee bit of background anxiety, and they also help with some joint pains as well. So they are very useful and they do work. The only two I ever recommend are venlafaxine, long acting, and just a tiny dose, so 37.5 milligrams, so the very lowest dose you can possibly get, or escitalopram, again, at the very lowest dose, 5 milligrams. So these are ultra low dose and not standard antidepressant doses, but they work really well for menopause symptoms. Now, the problem with any antidepressant is that it can lead to weight gain and some bone thinning and some low libido and issues having orgasms. So they do have their drawbacks, and venlafaxine can be a bit difficult to come off as well. So it works brilliantly, but does have some side effects and difficulty withdrawing from it. So it's really important that women know this before they be tried on it. And for women that are menopausal after breast cancer might be on tamoxifen, Again, you've got to be really careful about what antidepressants you use. So again, venlafaxine and escitalopram are perfectly safe and don't interact with tamoxifen. Some TPs know about the standard ones that interact, like fluoxetine, paroxetine, but they don't know about the kind of the moderate interactors. So you best just stick with those two. There are other medications, pregabalin or gabapentin, and these are useful again for flushes and sweats, anxiety and joint pains. And they do work, but again, they've got issues with fluid retention and weight gain, lower libido, and again, they can be really difficult to withdraw from. So you just got to be a wee bit cautious with them. The new kids on the block at the moment for menopause flushes are what we call the neurokinin 3 inhibitors, and they work on the thermostat in the brain. And you might have seen, it was all over the media and the news the end of last year that Veoza was licensed in the UK for menopause flushes, and it works brilliantly. It works within days. I think it's going to be a game changer for women with menopause after cancer. It's non-hormonal, and it literally just works for those flushes and sweats within a few days. Works really fast with very, very few side effects. At the moment, we're waiting for it to be approved by NICE, to be approved for use under the NHS. So it's only available privately at the moment, but there are trials starting all across the UK for women with breast cancer and menopause, and they can enter those trials. And for women that are interested, if they speak to the breast cancer nurse, their breast cancer nurse will know whether their unit is taking part in those trials or where their nearest kind of trial unit is. There are trials called Oasis 4 that are ongoing at the moment for elazinitant, which is a very similar medication, and they're going so well that they've been extended. These treatments should be available under the NHS really shortly, and it looks like they're going to be a game changer for us.
That's brilliant. Thank you. I'll move on now to the next question, if that's okay. So over to you, Sarah.
Hi, Alison. In addition to the physical symptoms of medically induced menopause, some of our mums also experience psychological symptoms such as anxiety and depression. What support is available for our mums at this time, and how can they access it?
You may well start with the physical symptoms of the menopause, such as your flushes, but then that will often lead to the psychological symptoms simply because you're not sleeping or you're just exhausted, and that leads to low mood, anxiety, depression. So often, if you can improve some of the physical symptoms, you can improve your psychological symptoms as well. But first off the bat, that I would say your first point of contact is your cancer nurse. So if you've had menopause after breast cancer, it's your breast care nurse. If it's menopause after gynae cancer, it's your cancer nurse, because every unit's a wee bit different and will have access to different services. And so your cancer nurse will know exactly what services you've got available. If it's menopause after breast cancer, then Breast Cancer Now also has nurses that you can just phone up. So you just Google the charity and you can speak to a breast care nurse. They're available 24/7. And they also do fear of recurrent courses and moving forward courses. And then Macmillan Cancer Support have their own courses available as well. If you've got a menopause after gynae cancer, you can access them for support. I work with Maggie's, and Maggie's are doing an awful lot at the moment with menopause after cancer. And you don't need an appointment for Maggie's centres. You just go down and you speak to them. And again, they will tell you what they've got available in their local unit. And they can offer face-to-face, kind of one-to-one session, one-to-one psychological sessions, or group classes. For instance, our Maggie's unit in Glasgow does cognitive behavioural therapy for menopause symptoms. And I think we're going to talk about holistic treatments for the next question. So I'll save the explanation of what that is for that. But they offer group classes, and then they also offer a lot of kind of group psychology and one-to-one counselling support. So again, your breast care nurse or your cancer care nurse will know exactly what's available in your area. I also the medical advisor for menopause and cancer charity run by Danny Binnington, and that's for all women who've had menopause after any cancer. And we have a podcast on that every single week. That gives a ton of information and support. Danny also has some face-to-face and group sessions, and she'll have workshop days as well. Often we do that in combination with Maggie's, but sometimes there's standalone events or at Future Dreams House. Again, that's for breast cancer specifically and menopause, but there's events there as well. And again, other things available is you've got Trek Stock, your obviously Mummy Star charity, and Future Dreams. With regard to psychology treatments, we've got cognitive behavioral therapy, which is great for anxiety, and cognitive behavioral therapy for insomnia as well. What I would say is if somebody is struggling psychologically, then ask your cancer treatment team to refer you to a psychologist so you can access those talking therapies. So you can get CBT for anxiety or CBT for low mood, but there's a specific CBT for menopause symptom. And that is actually, it's got really good evidence to show it works really well for your flushes and sweats, but also anecdotally, it helps with anxiety and insomnia. Your local units may do group classes. Maggie's do group classes. Certain other cancer units will do group classes. And you can also, if you Google the Women's Health Concern website, they've got a really good leaflet all about cognitive behavioral therapy. And there's a workbook that goes along with it that you can buy from Amazon by Melanie Smith and Myra Hunter. And it's called Living Well Through Menopause. And that talks you all the way through CBT. So that works really well for the anxiety, the low mood, and the flushes. And then there's something else called CBTI, which is CBT for insomnia, because again, insomnia is a significant issue. Over 80% of menopausal women will experience this, especially after having a crash menopause. Poor sleep will spiral and really make you just feel dreadful. There's the Sleepio app. Everybody in Scotland has free access to the Sleepio app. In England and Wales, you can access that through Macmillan. And what it does is it basically talks you through how to get a better sleep regime and sleep habits. Because the problem is if you're not sleeping, then your bedroom becomes a battleground. And we say your bedroom should just purely be for sleep and sex. But if you're not sleeping, it just becomes this battleground. And as soon as you then go into your bedroom, your senses start getting stimulated because you're just going to lie there and not be able to sleep. So CBTI teaches you, and it can be quite difficult to do initially. It's worth using either an app or there's a really good podcast on the menopause and cancer podcast on about how to sleep with Dr. Zoe Shandel, who's a sleep specialist. And essentially, you're initially restricting sleep and training your brain how to get good quality restorative sleep. And then obviously there's all your exercise is going to help with your psychological symptoms. And then again, if you do need medication, then escitalopram or venlafaxine are probably going to be your best friends because they're going to help with your menopause symptoms, but they're also going to help with your mood issues. You would never use them kind of alone. You want to use them in combination with psychological therapies, whether it's counseling or CBT. And again, diet and lifestyle and exercise. The other thing you can try is, and we would always recommend that you speak with your cancer nurse about it, is you can use things like ashwagandha. That's good for stress. For most of the cancer medications, it doesn't interact with it, but it might interact with some of it. So we always say before you're going to take any supplements for your mood, always check with your cancer care team or your oncologist to make sure that it's not going to interact with your medication.
I think struck me about that. I think these are all the independent, signs and symptoms and psychological impact of menopause. Right? I think when you set it in the context, Jen, of our group of families, there is this perfect storm of, and you're also juggling young children with that, and you are also already extremely sleep deprived, and maintaining balanced diet and regular routine is already incredibly difficult. I suppose that similarity, but separation between psychological symptoms and societal impact of how that impacts your confidence and ability to just do the normal routine things that you would do. And in our setting, like I said, it's the ability to want to go to those classes and sessions and do things with your newborn baby or other young children in the family, but yet you have this layer of menopausal impact on top of that, and knowing that your other peer group within you and within those groups isn't necessarily going to be experiencing or have an actual understanding of what you're potentially going through, or why you may withdraw certain groups, or why you may not interact in the things that you usually did interact with. And it's some of these kind of things are the things that families share with us, anecdotally from time to time. And it's particularly pertinent to the sleep deprivation. I think all of us, we always spike up and go, but there's a 2-year-old or there's a 1-year-old, and that's already impacted.
Exactly. So I always say to women who have got preschool children, speak with your health visitor, find out what's available locally. Where I work, health visitors liaise really closely with Quarriers. And so what happens is that Quarriers will often provide extra support so that the woman then can access some of the services that she needs. So just don't be afraid to ask. Just ask your GP, your health visitor, your cancer team. There's always services available locally that people don't know about, that you can access. The other thing is that a lot of these charities do stuff online. So, for example, Future Dreams, which is a breast cancer charity, they do a whole load of exercise classes online. I appreciate it's really difficult to get to these face-to-face things, especially when you get young children or no transport or you're just feeling exhausted, but you can still do these things online. And you might get disturbed several times, but at least something is better than nothing.
That's fab. Thank you. Right, I'll move on to Jenny. I appreciate we might have covered some of what Jenny's done so far, but there might be some additional information as well. Jenny, over to you.
Hi, Alison. This is in relation to more holistic approaches. For a lot of our mums following their cancer treatment and have had lots of medication, they might be reluctant to take any further medication. So could you describe any holistic approaches that they could try that might help improve their symptoms and just make them feel more
Yeah,
in
so
control?
with any menopausal women, for whatever reason, you always start off with healthy diet and lifestyle. So it is basically, your Mediterranean diet. And women always ask me about, oh, should I do a fasting diet? Should I do this diet? It might not do you any harm, although obviously we don't recommend fasting diets during chemotherapy. But there's no evidence that those type of diets help. But the one that we've got the biggest amount of evidence for is your Mediterranean diet. So that's your kind of fresh fruit, fresh veg, oily fish, pulses, nuts, that sort of thing. That is going to help with menopause symptoms, but it also reduces the risk of heart disease, because the issues with menopause, so any postmenopausal woman is at higher risk of things like heart disease and osteoporosis and kind of like joint pains. So it's so important that we're not just thinking about the cancer, but we're thinking about your long-term kind of health prevention. So thinking about keeping your heart healthy, your bones healthy, your brain healthy. So it's your Mediterranean diet is the one we always recommend. And then obviously, I know we touched on it before, but exercise. So to prevent osteoporosis, it's your weight-bearing exercise. So that's your walking or your jumping. You don't need to be running marathons or anything. Just, get out for a walk, stick the baby in the buggy and just get out there. Whatever you can do to do it. And even if it's just 5 minutes, it's better than nothing. So your weight-bearing exercise is going to protect your bones. And again, we also know how important a weights program is. So get a set of resistance bands or cheap hand weights. Some charities like Maggie's are doing exercise and weights classes, but I appreciate it might be difficult if you've got young ones to get to them, but there are those available. Pelvic floor exercises, we touched on that before, really important for your urinary symptoms, your urinary leakage. Yoga and Pilates. So again, do it online. There's full load of free online yoga classes. I love yoga with Adrian. It's free. Anyone can access it. You can dip in and out of it. She's an accredited yoga teacher, and that's going to help with meditation, relaxation, and sleep, joint pains, joint stiffness. Many women say to me, I can't exercise because I feel so exhausted and my joints are hurting, and I'm worried about making my joints worse if I exercise, but it's the opposite way around. You need to keep moving, and movement is going to help with your joint pains and help with your energy levels. So just so important to keep exercising, keep moving, however much you can do. And then we spoke about the cognitive behavioral therapy and the sleepy apps. We spoke about vitamin D. So vitamin D3, really important. And vitamin D is going to protect your bones. Again, your increased risk of osteoporosis from the cancer treatments, especially ones that turn your ovaries off. So your vitamin D3. And also you need adequate amounts of magnesium to be able to get your vitamin D to work properly. And again, women will have lots of kind of joint pains, joint stiffness, muscle aches and pains, and for the sleep as well, magnesium is really helpful. Now, if you went into Boots or Holland and Barrett and bought magnesium, that's the wrong magnesium. That would be magnesium citrate or oxalate, which is the wrong magnesium. That's just going to bum you up or make you constipated or affect your bowels. You want magnesium glycinate for sleep. One of the best products that I recommend to all of my ladies is BioCare Cam Complex. You can get that from Amazon or directly through the company. That has magnesium glycinate in it, but it's also got something called L-theanine in it. L-theanine stimulates your GABA receptors in your brain, and it's your GABA receptors as your body's natural sleep, sedation, anti-anxiety receptors. So the magnesium glycinate is going to help with that. The L-theanine is going to help with that. And it's got things like lemon balm and basil in it as well. So all sorts of good stuff that's going to help with the kind of the sleep and anxiety. And so for all of my patients, I say, as long as you're having a healthy diet, then really the only two supplements you need is your vitamin D. And I would go with that magnesium glycinate, your BioCare Cam Complex. If you go on the Royal Osteoporosis Society website, they've got a really good calcium calculator, because a lot of women think, oh, well, I need extra calcium, but actually too much calcium can harden your arteries, so we don't recommend that anymore. So if you go on to the Royal Osteoporosis Society and you just basically look for the calcium calculator, you just plug in what you would normally eat in a day, and it's telling you if you're having enough calcium in your diet. If you're having a healthy diet, you should be having enough calcium and you don't need to take excess calcium. And then there's supplements like omega-3 that's going to help with joint pains, joint stiffness, keep your heart healthy. Then magnesium glycinate is going to help with muscle spasms. A lot of women get woken up with kind of muscle spasms, which are really unpleasant. And magnesium glycinate helps with that. Turmeric is good for joint pains and joint stiffness. But the only thing with that is that if you're on tamoxifen, it can interact with that. So it's fine with most cancer medication, but not with tamoxifen. I always say if you're going to take any supplement, check with your cancer team and make sure that they are okay with you taking it. Especially with tamoxifen, there are lots of interactions with it with regards to many medications. Always check with the pharmacist or your cancer team. But if you're not on tamoxifen, turmeric's really good for kind of joint pains, joint stiffness. You can add in a black pepper to that as well, and that helps with the joint pains. A lot of women use collagen for menopause symptoms, like kind of the hair thinning and again, the joint pains. For most women, collagen is fine, and there was a bit of concern around social media, well, collagen will make my cancer grow. It doesn't. That's not the case. It's fine, but again, just check with your oncologist. But for most women, they can safely take collagen as well. With regards to supplements, there is actually a very good podcast on the Menopause and Cancer podcast with an oncologist called Dr. Toplinski. And she goes through all the supplements and all the interactions and can you take it or can't you take it with your cancer treatment. So that's a very good podcast that I recommend to all my patients. Another good podcast, as I say, is the sleep one with Dr. Zoe Shandel, who is a sleep specialist, menopause specialist, and that goes through the CBT for insomnia properly. And then the third podcast is one with Dr. Angela Wright, who is a clinical sexologist as well as a menopause specialist. And that talks you all the way through libido, because libido is so multifactorial. If you've had a surgical menopause or any menopause, your libido is going to be in your boots. If you've had your ovaries whipped down, your testosterone is going to be in your boots. If you're not sleeping, if you've got young children, if you've got your genital urinary syndrome menopause, so your vaginal dryness, itching, again, it's the last thing you want to do. And that causes a lot of relationship issues as well. So that libido podcast is a really good one. And then also, holistically, it's really important to treat that genital urinary syndrome of menopause. So we would always recommend, but you wouldn't dream of not moisturizing your face or your body. So moisturize your vagina. So every single menopausal woman, for whatever reason they're menopausal, we would recommend a vaginal moisturizer. And these are all non-hormonal. Yes, is prescribable under the NHS. Because it's really important you don't just go into Boots and grab a vaginal moisturizer off the shelf, because you have to have it pH balanced. Your vagina should be lovely and acidic. So you need one that's pH balanced and not got lots of nasty parabens and glycerol and additives in it. And nobody needs ones full of glitter or all perfumed. So yes, vaginal moisturizer is prescribable across the UK under the NHS. And this is basically a non-hormonal vaginal moisturizer. And then I say to all my women, don't even attempt to have sex without using lube. And again, yes, moisturize, yes, lubricant, purely just for sex, but that's available under the NHS as well. So you can get your GP to prescribe you that. Again, your cancer units, they well have samples. We've got a bucket, a huge bucket in the waiting room, and we just give out loads and loads of samples that you can try. Coconut oil. That's another really good thing you can use. Organic coconut oil. If you go to Holland and Barrett and buy the big tub, the stuff that you took with, the hard stuff, you can use that on your vagina and labia, and that's fabulous as well. I'm going to leave HRT to the side. We're not going to discuss that, but a lot of women think that vaginal estrogen is HRT. It's not. Vaginal estrogen is local estrogen to the vagina. It doesn't get absorbed systemically. And virtually every woman who has had menopause after cancer is going to really struggle with the genital urinary symptoms. And virtually every woman can safely have vaginal estrogen. The only caveat I would say is if you're on an aromatase inhibitor, so if that's letrozole, exemestane, or anastrozole, or if you've had a womb cancer, then speak with your cancer team. But everyone else can safely have vaginal estrogen. And even those two circumstances that I discussed there, actually you can have vaginal estrogen. You might just need a wee bit of tweaking. But essentially, it's really important to get some localized vaginal estrogen, because the reason that women have symptoms is because the lack of estrogen in the vagina, the bladder, the urethra. So you get all this kind of drying discomfort, inability to exercise, inability to have sex, but also it can lead to urine infections, which can be significant. And then women get given buckets full of antibiotics. That can lead to resistance. It can lead to temporary harm to your kidneys. And in rare circumstances, it can lead to urosepsis, which can be very serious to have that. So it is actually really important to talk to your team about using vaginal estrogen. there are various ones in the market, and I use the ultra low dose ones. I call this my waxy bullet of goodness. And if anyone has ever heard me speak before, I always talk about my waxy bullet of goodness, and this is in badges. And what this does is it is just a waxy bullet, and you pop it in your vagina and it melts in the vagina, and it's really moisturizing and lubricating. It is the lowest dose you can possibly get. It is minuscule doses, and when you use it long term, after 12 weeks of use, there are 0 levels of estriol in the blood. So this is ultra low dose. You can have this, or there's something called Blissful Gel. And I deal mainly with breast cancer patients. Our treatments, especially with the aromatase inhibitors, really suck every last bit of estrogen out of you, including the pelvis and the vagina, where you get real significant dryness and irritation. So Blissful's another one. It's a water-based gel, and you can use that inside and at the outside. And again, this is ultra low dose. And then you can get Ovestin cream. And again, you would just use a wee pea-sized blob. Now, these kind of products, the gel and the cream, come with hard plastic applicators. And I always say, chuck the applicator away. Don't use it. Nobody needs to stick a plastic applicator up their already dry, sore vagina. So just chuck it away, put a wee blob in your finger, and use your finger and just pop it into your vagina and externally as well. So these, I would say, after using your moisturizers and your lubricants, these are your kind of 3 products that I would recommend every woman to take. And as I say, if you're on aromatase inhibitors or if you've had a womb cancer, do speak with your team. But even in those circumstances, we still use these. And these do not get absorbed into the bloodstream, do not increase your risk of cancer recurrence. There are higher dose ones. I just stay away from those and use the ultra low dose ones.
Thank you. I'm just going to go back slightly just for your conversation about exercise, but just to give a nod to actually a lady who's a multi-star family, but runs an organization delivering cancer exercise sessions via Future Dreams called Sarah Newman, or it's Get Me Back UK. Sarah can be contacted directly herself anyway, and it's very bespoke, retrained after her own diagnosis. There's a lot of personal insight as well as to those onward benefits to exercise as well. Alison, the question that we mentioned earlier on at the beginning of the session that we had with our families, it was a situation where somebody's about to come off Zoladex after 5 years, but he's going to remain on tamoxifen for another 10, which I'm sure is probably something that many of our families may well be in that kind of situation. So the question was about what side effect changes could they potentially experience from ending Zoladex, and it was just that the anxiety that comes with the what ifs, the buts and maybes about changing any treatment, but particularly I think when it's so interlinked with potential menopausal impact as well.
Sure. So what Zoladex does is it turns your ovaries off. So it stops your ovaries producing estrogen. And it actually really depends how old this person is. Because essentially what usually happens is you've had chemotherapy before the Zoladex. You may or may not, but most women will have had. So if you're young, if you're under 40 and have had chemotherapy and then Zoladex, then your ovaries will hopefully come back to life. If you're over 40, then generally the chemotherapy just stuns the ovaries into submission and they just pack up and go home. And then your 5 years of Zoladex, as I say, keeps you in chemical menopause. But if you're over 40, then your ovaries may not come back. So to answer your question, if you stop the Zoladex that's keeping you in chemical menopause, your ovaries may or may not spring back to life. If your ovaries spring back to life, you should actually feel a lot better off the Zoladex because you're no longer being kept chemically menopausal. Which obviously for most women is going to be a good thing. But then you start having to consider, okay, what do you do for contraception? Because tamoxifen is not a contraceptive. And I think lots of women think tamoxifen makes you menopausal. It doesn't. It gives you menopausal symptoms, but it doesn't make you menopausal. So if you are young and have come off your 5 years of Zoladex, you'll have another 5 years of endocrine treatment to go, possibly. And so you do need to think about, okay, are my periods going to return? If they do, then you can get pregnant. And so you need to think about contraception as well. So I always have this conversation with women, okay, when you stop the Zoladex, we don't know if your periods will come back. If they do, or just simply by stopping the Zoladex, you actually should feel a lot better because you're no longer menopausal. But if your ovaries have already packed up and gone home, then you're actually not going to notice any change at all because you're just continuing in menopause.
There's a lot of herbal and alternative remedies out there, and menopause is obviously a big subject at the moment. Is there any of these sorts of things that people should be aware of to not take in terms of interfering with their treatment or going forward?
A lot of them are fine, but the problem is that obviously everybody's cancer treatment is very individualized. So certain of the herbal medications will interact with certain cancer treatments. So you can never have this kind of generic, everyone can take this and no, you need to stay away from this. So things like turmeric is fine for most women, but does interact with tamoxifen. So you have to be careful with that. Black cohosh is very good for sweat, but it can lead to some liver issues. Now, that's normally temporary. And actually, it's not nearly as bad for the liver as we previously thought. So again, most women can safely use black cohosh. But if you're on certain cancer treatments, it might interact. So you will just need to check with your oncologist or the pharmacist. Some of the cancer units will have specific pharmacists attached to them that are very good at kind of researching what supplements you can safely use with your chemotherapy treatments or whatever long-term cancer endocrine treatment you're on. Things like vitamin D, magnesium glycinate, they're all fine and nothing's going to interact with those unless you've got issues with your magnesium levels, say from chemo. So it can be a wee bit nuanced. Omega-3 is fine for all. Ashwagandha is great for anxiety. And again, virtually all women can take that. So it really does depend on what treatment you're on, and always check.
Linked to that, I mean, this struck me earlier on. I think we were talking about calcium, and you were explaining that there's a calcium calculation tool. It made me think, and I'm sure some people might look at the benefits of some of the things that you talked about today, and it might raise the question: well, why not take them anyway? Why wait until I'm potentially experiencing menopausal symptoms? So, with many of those things that you talked about, are some of these that your body naturally already has a good level of, then you shouldn't necessarily be supplementing that in addition. Like when you talked about something that's good for anxiety, was it ashwagandha? People could ask themselves, well, why not then take them anyway before it gets that bad? So are there safe levels of things that you maybe really shouldn't be taking until you've had that consultation or conversation about the symptoms occurring first before starting to take something additional?
Yeah, so with things like calcium, that's why we recommend going on to the online calcium calculator, because we used to in the old days chuck everybody in calcium, magnesium, and vitamin D supplements, but too much calcium can harden the arteries. So in situations like that, you don't want to be taking too much of a supplement. If you take too much vitamin D, then it might lead to things like kidney stones. So you always wanted to stay within the recommended levels. If you're not having any symptoms, then there's medication for symptoms, or there's purely just things you can do for long-term health. So for long-term health, it's every single woman should be on vitamin D because we can't get enough vitamin D from our diet and we need sunlight to metabolize it. Probably in the south of England, you'd get away with not having vitamin D for the summer month, but pretty much everywhere else, you're going to need your vitamin D supplements. So it's easier just taking it all year. But as long as you stick with standard doses, so the dose we recommend is 1,000 international units, which is 25 micrograms. So if you're staying between the 20 to 25 micrograms, everyone should have that. But with regards to other things, well, with diet and exercise, again, you should be doing that to protect your health long term. With regards to certain medications for certain treatments, I don't know, oxybutynin for flushes or the kind of ultra low dose medications for flushes, I would say don't take these unless you need to take them. So always start with diet, lifestyle, the CBT for flushes, the magnesium for sleep. Always start with that, and then you can add in your medication for whatever symptom, because the important thing to remember is the symptoms you're having now are going to be different to symptoms you might have in a couple of years, because menopausal symptoms will change with age, change with time since treatment. You become naturally menopausal anyway, and change with your circumstances. You might have flushes now. That doesn't mean in 2 years' time you're going to have flushes. In 2 years' time, you may not have any symptoms, or it might be joint pains that are your worst. Things change.
Alison, it's been an absolute pleasure having you with us. I always find conversation on menopause really insightful, and I think anybody who's watching this back, if you're watching it for your own benefit because you're struggling, please equally, once you watched it, share it with people that you know, share it with family, with friends, with partners, encourage them to watch it, encourage people to understand how much of an impact this has on people from all the different facets that we looked at within this session. But I include health professionals in this as well, if you don't mind me saying that, Alison.
Oh, absolutely.
I think all disciplines would benefit greater from having a better understanding of how this impacts people. And we do hear that there isn't necessarily always that joined up conversation between the joy of being told that you are in remission, matched up with a conversation about, but you will also potentially start to experience these symptoms. And I think we all have a mutual role in making sure that conversation is as joined up as possible as the conversation about menopause, while thankfully getting much wider attention now than it is. I still think the individual aspect of it, I think we don't want to lose within that as well. A huge thank you from myself and from the team and anybody who's watching this today, or also when we have it on our website, which should be in a few days. Huge thank you for your time, Alison.